There we go. Okay. I'm gonna turn off my camera because I think it's distracting. All right. So as you can see, this is an old lecture of mine, which I wrote as a fellow, but most of this has not really evolved because these pathogens remain the same. So this one I feel like is perfectly fine for us to give today on short notice. So what we're going to do, we're going to talk about gastroenteritis definitions, epidemiology, and burden of acute gastroenteritis, clinical definition between notable pathogens that cause AGE, what the SPGAN guidelines versus NASPGAN doesn't really say anything, and then changes to U.S. practice that we would suggest. And I'm going to go into some other stuff that I'll talk about more extemporaneously based off some work I did from things I discovered initially writing this lecture. So acute gastroenteritis, official definition, 2 or more stools over what is regular. All right, so this is what the difference is. Diarrhea is a description of stool consistency. Gastroenteritis is a description of having frequent stools and a texture change. Those are different things. You can have poop, you have ongoing issues with this that are still happening, and you just have loose poop, but it doesn't really count if it's not more than 2 more than your regular a day. And what's handy is this also accounts for the fact that babies have very irregular pooping habits. And it's hard to say, oh, you pooped 8 times today. And it's like, well, that's normal. So that doesn't really, you have to know what the baseline standard is. Now, there is a really important factor based off of what the timeline looks like, which is to say that if you are less than 2 weeks, it is definitely acute. If it is greater than 2 weeks, it becomes persistent. At 6 weeks, it's chronic. You don't really need to do anything in almost all cases in less than 2 weeks. You just watch it and support it clinically. It is almost always fecal oral spread. This is gross and people don't like to think about it, but people are constantly leaving traces of that sort of material, and it spreads with close proximity, even with hand washing and other stuff, although those things are protective. You usually get onto the symptoms about 12 hours to 5 days after exposure, and about 3 to 7 days of active symptoms. The typical pathway for this is that you end up looking at someone throwing up or having abdominal pain up front, followed by maybe some mild cramping and ongoing loose stool, which is the lagging tail of the disease. This can last up to 7 days more, which is why we say 14 days is the average time or the time that we're really comfortable with calling something acute gastro. But generally, it's about 3 to 7 days, and really the acute phase is typically 24 to 72 hours. So there are 179 million cases annually in the US. This is an old number. I don't know what the current number is, but we could find out on Trinetics, and maybe we should. There are 9 admissions per 1,000 cases in kids, which is over 220,000 admissions annually. This is a cost per admission of, let's see, does that say about $1,500? I can't read. 3,500? 3,500 for a $1 billion cost annually. This is, not optimal. And everyone thinks, oh, in the US, like AGE is not a big deal. Well, it's not killing that many people, but it does kill some people. And that's dumb. And it costs us an insane amount of money and time. And so this is really, really silly that we are now seeing declining vaccinations, especially for norovirus, which is really wild, or for rotavirus, which is really well tolerated as a vaccine. So this is always a trick question that oscillates a little bit these days about which one is the most common cause, but the answer is almost always viral. And the answer is that it's a mix between rotavirus and norovirus. Norovirus is the most common epidemic cause. Rotavirus is the most common cause broadly. Almost always rotavirus is the most common cause. Every so often, there are epidemic years of norovirus that are impressive, and norovirus takes the cake. But generally, you really are thinking rotavirus if somebody is sick with gastro. There are other things that do this. Look at all that long list of viruses. Pretty much all viruses. It's pretty much all viruses. So you're looking at overwhelmingly virus. Now, the other thing that here is that it doesn't really matter if it's bacterial, because what's the main side effect of antibiotics? Yeah, does that seem helpful? Yeah. We're not going to fix your diarrhea with diarrhea. It doesn't go very well. So broadly, it doesn't work. And there are other reasons we'll talk about a bit more about why we don't recommend using antibiotics broadly. There are common parasitic things we see. Giardia is one of the biggest ones you'll see in the US. But you can also see cryptosporidium. Typically, you'd expect someone to be immune compromised if that's there. Entamoeba histolytica is our favorite friend visiting us from Central and South America, although we should expect to see substantially larger amounts of that in the United States these days because of increased temperatures and water tables. And so we are really going to be looking at kind of all those things. Now, there are a lot of other parasites that can do this. We see a lot of those in Brooklyn, but they are esoteric and you just have to look for them. So I'm not going to make you memorize them. This is a seasonal illness. This is very interesting, but it has a lot to do with when we are in close proximity to each other. So you end up seeing oscillations that change. It also has a lot to do with other behavioral patterns, as in, are we barbecuing? These are related things. So basically, the likelihood of getting gastro has to do with, are you spending a lot of time around other people? And are you touching meat? These are the things that tend to be big predictors. These are the states where nobody washes their hands or where you see epidemic acute gastro outbreaks. This is, of course, generally a map of the North. And you might be like, wow, that's weird. You'd think that people in the South wouldn't wash their hands as much. And that's true because this is a sassy answer, but not actually a real map of where people don't wash their hands. This is a map of where people's environments spends much of the year being unpleasant. And so you end up basically dealing with that. It's also a map of animal culture, which is a major thing about gives you acute gastroenteritis. But this is generally where we see the biggest outbreaks. As you can see, New York, a very, very cleanly and hygienic space, not on the list of overall most outbreaks because everyone here washes their hands because this is the greatest city in the history of mankind. Rotavirus. This is the prototypical acute gastroenteritis. It's the most common cause worldwide and in the US. It causes a lot of visits. It's a double-stranded RNA virus with seasonal peaks. And it has basically been not eliminated at all, but heavily mitigated by vaccines. Vaccines are fairly effective for rotavirus, very well tolerated. As you know, they're orally administered, and they work really well. Now, this is a really great case for explaining to people how vaccines work, which is to say that they are not, in fact, a force field. They are a wall. You can get over a wall if you bring enough of your buddies. And so rotavirus always brings a lot of its friends. So your goal here is not to make it so that you never get rotavirus, which the vaccine will not do, but to make sure that you get rotavirus less. And if you do get it, it's less severe, which it does do quite effectively. So the virus is destructive by basically killing the enterocyte as well as causing some secretory diarrhea. And I'm going through the mechanisms of some of these as I go through because I think it's interesting. And I don't necessarily have a better reason than that. Norovirus. Nice picture of a norovirus in the upper right. This is the reason you don't go on cruises. This is what happens when cruises turn into giant seas of diarrhea, which apparently happens enough in that it has happened in a thing I read online that I am not going to go on a cruise. Also, I don't fit. I am very tall. So we're not going to do any of that. So norovirus cruises do not have lasting immunity, but also norovirus doesn't either. So this is why you can still see epidemics of this. Vaccinating for it doesn't do much. Giving somebody having previous experience having norovirus, all of you have almost certainly had this, does not give you much protection. It does not last very long. So you end up getting epidemic spread because everybody forgets, because your immune system just forgets what this is and doesn't recognize it, and then you see giant problems again. Additionally, acute gastro and viruses that cause it are really, really effective for causing epidemic spreads because they are really good at bringing a lot of themselves. When you get gastro, you see a lot of viral shedding and typically a lot of waste material and effluent that somebody is dealing with and thus getting infected. So it is a lower severity generally than rotavirus, but and tends to be a little bit shorter duration, but does spread extremely effectively. And it is, basically maybe getting somewhat attenuated if you've had rotavirus or rotavirus vaccination, but hard to say. Salmonella, this is the most common cause of bacterial. So this is a gram-negative bacillus. It is a intracellular pathogen, meaning it hangs out in the cells. The thing that this does that makes it really annoying is this creates long post-infectious shedding times. So if you have salmonella, it's going to hang out inside the lining of your intestine and just sit there, not getting killed by your immune system and doing other stuff, and eventually it'll finally wash out. Non-typhoidal is the most common cause. This is typically secondary to food. You cannot tell the difference between other gastroenteritis. You don't see anything that changes the difference. They have fever, they have vomiting, then they get diarrhea. It lasts from 4 to 14 days. You might recall that from everything I've said so far. So you're not going to see a big difference clinically. And very rarely it will actually become bacteremia or become a more concerning version of the infection that could be typhoidal or other issues like that. And you are really going to see some problems there. And that sometimes does require direct medical treatment as opposed to just supportive care and therapy. So typhoidal salmonella, this is the not happy one, and this is the one that they unfairly maligned all people named Mary for. So it is the cause of typhoid or enteric fever. There are about 27 million cases annually and about 200,000 deaths. So this is not ideal. This pretty much only spreads through humans, which means that you can basically find carriers, which is again relevant why this is an intracellular bacteria. It likes to hang out, and people can be chronic carriers. And the issue here is that this one has both a long incubation time, which means you're shedding it for a long period of time before you know you're sick, and then quite high severity in some cases. So you end up with some big problems with the typhoidal version, which can be both dangerous from the severity of the vomiting and diarrhea and dehydration, and can also cause other issues like bleeding and other problems. E. coli. This is why you avoid fast food. I would particularly say that you want to avoid fast food in the coming regulatory market, where I don't believe the FDA is doing anything to look at meat. So you are generally going to want to not do that. So, yeah, E. coli is weird, right? Because E. coli is generally your friend. E. coli does a lot of nice things for you. There are a lot of friendly versions of E. coli that live in your intestine that you are like, hey, guy, you're great. But every so often, E. coli gets a weird email from its friends and it goes insane. I don't know what that is or why it has to do that, but it does. So basically, what happens is it picks up genetic material that makes it start to express different things, and those things make it a different type of E. coli. Those E. coli are considered things like enterohemorrhagic E. coli or EHEC, which has a Shiga toxin ability, which basically means it makes Shiga toxin, which results in you having bloody diarrhea and a bad time. This is a very dangerous infection, and this is another reason why you generally do not want to give people things like antibiotics in these cases without just willy-nilly, because you can create things like hemolytic uremic syndrome. Enterotoxigenic E. coli or ETEC is the most common cause of traveler's diarrhea. So if you go someplace and you eat some street food like I do and you get sick, like I don't, but my wife does, almost certainly you manage to get yourself ETEC. So this is, generally looking at something very similar to cholera toxin. So you're increasing cyclic AMP. This will cause chloride secretion and push water out into the lumen of the intestine. And then you end up with some, increased diarrhea, increased transit through the intestine. This is generally a self-limiting acute gastroenteritis, not particularly severe. Now, it's worth noting what causes bloody diarrhea or bloody gastroenteritis, because these are the ones that you might think about actually doing something for. In general, every kind of gastroenteritis, what you're going to do is supportive care because anything you do is likely to make it worse or create side effects that are essentially the same as the disease. So, for the most part, you're not going to touch anything. However, if somebody has bloody diarrhea, you're going to think about it, and it's going to definitely make you want to test and find out why they have bloody diarrhea. So, common sources that we see in the US from infections include Campylobacter, Salmonella, Shigella, Yersinia, C. diff, and EHEC. These are all reasonable to test for and consider treating. Although EHEC, I would have some resistance to treating. Same thing, some of these other ones. So you do want to basically consider assess. You want to assess and get a culture or a PCR for these, even though normally you would not bother. So now we're going to get to the management. So given that this is super common and all over, you'd think that we would have some more guidelines in the US about it, but we don't. We just say, hey, it's cool to get the most expensive possible version of care for this by sending people to the emergency room, putting IVs in, and we make sure people don't die, again, for the most part, but we don't do anything practical about it. And it's not a very helpful way to take care of it because it requires you to be in an instrumental place like a hospital or emergency room or an urgent care to receive that care. And the bottom line is you could do almost all this at home with just as high an efficacy and safety if we actually just bothered to incentivize or even legally allow some of the treatments that are well known to be quite effective for gastroenteritis. The American College, which is for adult GI, does have some guidelines. Some of those guidelines are actually contraindicated in kids. You should not give kids loperamide. Does anybody know why? No, opioid part doesn't get in the brain.
Deals with the motility and
It does decrease the motility and it does cause stasis. What happens if you're small and somebody is trying to pump a bunch of fluid into your small intestines or your general intestine? Small intestine is a geographic term. If you into your intestine and you have a bunch of inflammation and everything's really angry and mad and not moving normally, what can happen? Perforation. Doesn't happen frequently, but it does happen. And it happens specifically because physiology of small people is different than physiology of large people. So loperamide, not very dangerous for a teenager or above, but for people, kids under the age of 12, there have been absolute cases of acute gastroenteritis and loperamide resulting in perf. That is dumb and shouldn't happen. Loperamide doesn't even make you feel better, really. It just decreases the urgency and the frequency with which you go to the bathroom. It actually can worsen cramps. And so, again, if you are an adult and you need to be doing things to, earn a living or be alive or take care of your kids, then yes, not having to be in the bathroom is useful. But your kid doesn't need that, and it will actually delay their improvement and put them at risk. So generally, I'd like to make sure that people know not to use loperamide or Imodium in acute gastroenteritis in children. ESPGHAN and the World Health Organization do have guidelines. They are quite helpful and they work really, really well. However, they are not really commonly used in the United States, which is a little bit of a bummer. So these are interesting because one of the main things that is recommended in the ESPGHAN guidelines is a drug that's not available in the United States. It is, however, my strong recommendation to you that whenever you leave the United States, you buy this drug and you take it home with you because it will change your life when you are at home. This drug is called racecatril. It's an encaphalinase inhibitor. I'll talk about a little more, but it is in fact a really, really amazing and highly effective non-cramping antidiarrheal agent that has been in common use around the rest of the world for about 45 years with an incredible safety record. It has never been studied in the United States, and no one has ever tried to submit it to our FDA because it is very expensive to submit things to the FDA in the US, and no one has thought that this would get well adopted well because Americans generally don't take care of acute gastroenteritis effectively. However, it's an interesting thing, and I'm hoping eventually it comes. Biggest things that we suggest are oral rehydration solution. Here's the thing that people commonly don't do, and that can be a big issue, which is that we actually do recommend early resumption of feeding. We do not want you to do the brat diet. We do not want you to do a delayed diet. And we don't think it does not help to have somebody on gut rest unless your only goal is decreasing stool output. Decreasing stool output is not actually a good clinical goal. You want to improve the physiologic process, and all that's really doing is starving someone. So, generally, there's also appropriate pharmacologic agents. Zofran is a big one. This has actually seen major shifts during my career in terms of commonality of use. When I started, Zofran was barely used. It is now commonly used, especially in the ER settings. It should be used more in primary care settings. Does anybody know the safety of Zofran? Would you say Zofran is more or less safe than Tylenol? More. Yeah. Zofran is one of the safest drugs on the market. There has yet to be an attributable death to Zofran. There are two cases where people got 64 milligram IV pushes of Zofran who were both adult oncology patients who had torsades occur. It is unclear whether or not the Zofran was related to that. However, that dose is literally 8 times the highest dose I've ever given anyone. And thus, I don't think that really matters. I can also kill you with water, both through drowning or drinking. So you really people really overestimate the safety issues. There are two reported cases that FDA has of kids taking overdoses of Zofran. In both cases, the kid recovered fine. They were obtunded for 12 hours, no major issues or long-term problems. So broadly, like we should be using this more. It's quite effective. It reduces a whole bunch of things. and risk of return, and it is allows for hydration and return of early feeding, which is both really helpful. And basically, the biggest thing here is you never use anti-infective agents, like almost never, right? And I mentioned already, why not? Why not? Well, I mean, that's the minor problem, right? Like you're not helping, you're just going to make it worse. But there is one major problem that was the reason why we never use this. That's a medium problem.
70% of cases are viral.
It's always really viral, so it's pointless. So there's futility, there's C. diff, but there's one thing that could directly kill you. Mention it with E. coli. Yeah, what is that? Nice. That was a strong med student answer. It's not a side effect of E. coli. It's a side effect of killing all the E. coli at once. Yeah. You do kill those, and antibiotic use is problematic for long-term risk factors, other stuff like that. There's a lot of different minor reasons. Hemoglobin syndrome will kill you. Yeah. So that can absolutely kill you. So that is basically, especially when you have Shiga or E. coli and you don't know what you're looking at and you kill it and you kill all of it at once and it releases a big surge of toxin and it fries a bunch of things. It fries your kidney, it makes you get hemolysis, it causes a bunch of other secondary problems and can be fatal. So you generally do want to know what you're treating before you treat it, even if you think someone is indicated. What is a reason to use empiric antibiotics? This one will go to Mariam.
Fever?
No. A lot of people have a fever. Evidence of bacteremia. So evidence of sepsis, shock, evidence of bacteremia. Those are the reasons. Or you know what the bug is and yet it will help to kill it. So basically clinical instability or clear target. I keep losing my button here. So what's oral rehydration solution? This is the coolest thing. And I really feel like more people should know about it and just keep it around and have it available because it is just so neat. It is also one of the things that people also do wrong all the time. In addition to the brat diet and other stuff like that, people frequently think, oh, you can rehydrate on water. Why can't you rehydrate on water? What does that matter? I said, well, yeah, but that's sodium. I just want to rehydrate. You're out of water, right? So you lost all this water. If I just pour water into you, what's going to happen? You just come out the other end. You'll just have diarrhea. What happens when you have gastro? What happened to your intestine? Is it happy? Did someone come in and just start blowing stuff up? Yes. So it is denuded. It is not working. It has barrier defects. It's just not functioning very well. You've lost all your villi. Everything's unhappy. Nothing's working very well. The osmotic pressure is going to be mostly towards the lumen because there's no barrier, there's nothing there, blah, blah, blah. But there is something that you can do that will work against osmotic pressure. Huh? No, I mean, otherwise, water is the lowest osmolar. That would.
Put more content in sure.
Is that how osmosis works?
No.
Yeah.
Yes.
That's the opposite.
Right, because the water follows.
The more stuff is in the lumen, the more water comes into the lumen to try to make it equilibrate.
Yeah, water follows.
Yeah. So, but giving someone just regular water doesn't help because again, you don't have a great. There's still going to be stuff in the lumen. There's debris coming off the line in the intestine. There's not going to be good absorptive pathways. There's no solid barrier. But there is something that happens if you do not water and you use oral rehydration solution. What's in oral rehydration solution? So sodium, so salt and sugar. Why? Well, that would put again. The more osmosis means water doesn't go through, right? The more stuff you have in the water, in theory, you're making it more osmotically attractive. So you're going to have water come out from the bottom. No, but we don't want it in the lumen. We want it in your body. Yeah, but why? not that it really follows sugar.
It is replacing the losses,
Huh?
replacing the losses.
There is an active transporter.
The sodium transporter.
Yes, sodium glucose transporter will pump sodium and glucose and water into your body. So you have an active transport. That is always the solution, philosophically, to okay, the chemistry here is bad for your body to work, but it does. So what's it doing? Using energy to pump somewhere or another. You don't even necessarily know that. But this one you actually do need to know. It shows up on general boards, it shows up on PEDS boards, and it shows up on GI boards. And you need to know the sodium potassium glucose transporter. Okay, that is relevant. That is also why ORS is made the way it's made. So ORS is made to basically have what stuff in it. So it's got sodium and potassium glucose basically, right? So you are looking for this. Now, we used to think, oh, we just want to put as much in as possible because that's going to be the best possible option. And it's not entirely true. It's arguable that there is probably the more concentration, higher osmolarity ORS would potentially be more effective in exactly the right physiologic state and if it didn't taste terrible. When things taste that salty, they taste like blood. Most people don't want to drink blood. Most people. I don't speak for everybody. So in general, you don't really want that. The saltier it is, it does not taste good. You can't get people to do it. Even Pedialyte level salty, some people find too salty. I love it, but that's a separate issue. So in general, if you want to get kids to do this, popsicles work amazing. Freeze your ORS and it will do great. They will come 100% go to town on it because it doesn't taste as salty when it's frozen. In the US, the most common brand you're going to see is some Pedialyte, but you can mix this very easily at home with common kitchen ingredients, and it is amazingly effective. Nobody in the US recommends this to patients, not in the least. It doesn't happen. This number has basically not changed. We still see an overwhelming amount of use of IV for use of gastroenteritis with dehydration in the US, and it's really dumb because it doesn't work any better. Here's the mechanism, which I just spent a while hassling you guys about. And you do need to know this one. This one is really important. If you give somebody fresh water with wonderful, perfect water, completely clean, the purer, the worse, you get diarrhea. You just see diarrhea. So you don't need to do that. You want to make sure you're putting in sugar and salt with your fluids. That is how you rehydrate somebody. So the other thing to know about rehydration, how does it work? Dr. Miriam, I have to imagine you've done a lot of oral rehydration. So how do you orally rehydrate people? What's your workflow? What's the first thing you do? No, but like oral rehydration, right? When you're giving somebody fluids, oral rehydration solution. Yeah, but like how do you figure out how much to give them? And how do you tell them how to do it?
It's 60 ml something.
Okay, so there are standardized approaches to how you figure this out. The first thing you do is assess what you think the dehydration level is. If you are sitting there with somebody who can tolerate PO, that's great. If not, then give them Zofran. If they go from there, the next point after that is you're going to essentially do an oral rehydration period, which is done over how many hours?
6 hours.
So you're more or less calculating a volume based off what you think they need, and then having them do a power hour, which, if you're not familiar with it, is a US fraternity tradition where you take a small shot of beer every minute for an hour. But in this case, you're doing it with oral rehydration solution, and you give them small amounts frequently so they don't overwhelm their stomach and puke it, and they end up being able to take it and absorb it practically. So you do that for a little while, and then after that, you give them a larger goal, which is a goal over a period of time. So I do want you guys to look through those calculations. It is necessary to do that as a general pediatrician. And then especially if you do end up working in any low-income environments, you're going to see a fair amount of acute gastro, which correlates very heavily to socioeconomic status, both at a meta level in terms of the country, as well as at an individual level. Why do you think that SES correlates with gastro? How's gastro spread? Do people who have more or less money live in closer contact? So the less money you have, the more space you have, the more people there, more likely to get gastro. It's pretty simple. So what about food? We want to rapidly reintroduce age-appropriate diet. This does feed recovery. Why do you think this feeds recovery? Sure, but what do you like? So when you have gastro, right? Something came in there and just wrecked the whole place. So you've got your villi are all damaged, your epithelium's all damaged. There's a lot of damage done. When you come through and have a hurricane, and the hurricane's over, is everything cool now? The hurricane's over.
Yeah.
You need to repair. What do you need to repair organic tissue? One simple answer.
Food.
Food. You need protein and fat. What's in the brat diet? Carbs. There are things that it will help in terms of symptoms. They are not going to materially change symptoms or duration, and it increases duration because it slows down repair of the epithelial barrier and regeneration of the villi. So you get decreased time or increased time to recovery because you're not regenerating your brush border enzymes, all the other functional stuff nearly as quickly. When we looked at this, it basically the only thing you can really see an impact on is if you return to diet faster, you get a decrease of diarrheal illness days. You might see a slight increase in diarrheal output, but the time that you spend having diarrhea goes down. And this is because, again, if you put food in, more might come out initially, but it allows it to heal. And you need that to have that get better. Zofran. Zofran's a 5-HT3 receptor antagonist. It's awesome. It's the coolest. If you don't have any at home, you should. I keep it around all the time. In my opinion, it should be over the counter. Again, because it is highly safe. There is a long-standing myth that Zofran is going to cause torsades. Zofran does have a very minor impact on the QT. It's about 10 microseconds. Not interesting. The NNT to prevent hospitalization for Zofran in gastro is 5. You should use it. It's really safe. It's really effective. You should give prescriptions to people. My general practice when I worked urgent care was that I would give people prescriptions for a 3-day course of Zofran if they needed it up to every 8 hours. The reason why I would do that is because if you got past 3 days and you were still needing Zofran, it suggested that there was maybe a clinical need for you to be seen by a doctor again. But I very rarely had to see anybody again. Very rarely would they bounce back. This just allows you to start eating sooner. And it's worth doing even if the main symptom that remains is anorexia, because the secondary anorexia after acute gastritis is ameliorated by Zofran, and people will start to eat, which will make their diarrhea get better faster. So this is how you help someone get better faster. With gastroenteritis, there is nothing we can do directly to kill it or stop it, but we can do quite a lot to inflect how long you're sick, up to 2 days with appropriate therapy. And we can even do a lot of those appropriate therapies in the United States. We just simply don't, and we should. Diasmectite. Now, this is a fun one. I have actually tried to take this. I find it real yucky, but it does work. So this is called Smecta. It's a silicate of alumina and magnesium. It is available around the world, except in the US, although you can buy it on Amazon because it is a GRAS substance, so generally regarded as safe. What it does is it binds bacterial toxin and actually viral particles and prevents the interaction with the lumen. What this does is prevent the reinfection pathway that commonly occurs in acute gastroenteritis, and then decreases the duration of things, as well as binding some of the effluent and material to slow down transit through your intestine. This does work. I don't like the taste at all. And when you pour it into stuff, it looks like mud, but it works. It straight up works. So if you are really having a tough time, try diasmectite. Racecanetrol I talked about earlier, it's an encaphalinase inhibitor. I have a large stockpile of this at home that I pick up every time I am anywhere else in the world where it is available. This is an astoundingly effective drug. I don't know why it is not for sale in the United States. Encaphalinase inhibitors basically work by blocking secretion into the lumen, which decreases the volume and severity of diarrhea. This is sort of similar in some ways. Encaphalin basically is a partial opioid signal that is not really motility related, but has a lot to do with secretion. And so if you have encaphalin, it blocks cyclic AMP increases. The vast majority of viruses and bacteria that cause diarrhea work with a variation of cholera toxin, which is increasing cyclic AMP. So if you are going to block that effect, you are blocking chloride secretion. You're then blocking the fluid following it out, which means you end up with less diarrhea. But what you're not doing is stopping movement. So you're not creating a situation where you are pumping fluid and other material into the lumen while making it not go anywhere. So you don't create an inflatable balloon. What you do is just decrease volume, which makes this a safe and highly efficacious pathway that has minimal to no side effects. And I do not, again, understand why we can't have it, but apparently we're not allowed to have nice things in the United States. Probiotics. This is so up and down, and I feel like every 5 minutes there's a new study that says something different. But basically, this is not an official recommendation. There is probably a benefit to using probiotics that could shorten days of diarrhea by up to a day. There is unclear which probiotics will do that. It is also unclear if that benefit is worth the money. But if you have a lot of patients with a lot of money, you can suggest, hey, maybe this is worth trying. It might get you back on your feet a little bit faster. There has not been any major protective effect for severity. There's no other obvious benefit. There's really just a couple studies suggesting that it cuts a day, maybe 12 hours off of your days of diarrhea. So what not to do? So really, just don't use Imodium. Even for yourself, it's dumb. It just is bad. Like go get some racecatrol. Like just stockpile it, keep it at home. You'll be fine. Business salicylate, there's really not really any evidence supporting this. If somebody's getting better from that, it's just because they have some gastritis. It's really not going to help gastro itself. Zinc, this really does work if you're deficient. Zinc deficiencies are not particularly common in the United States. They happen in immigrant populations, they happen in people with IBD, but the main reason if you see a zinc deficiency, the probably most likely answer is it's because the lab did a bad job on the test. So we don't see a ton of this. So when you've looked at people trying to support zinc therapies in acute gastro, same way it doesn't really do anything for upper respiratory tract infections the way it does in the rest of the world. It's because we just don't have the deficiency. Zinc is quite effective at helping prevent and decrease days of illness in viral infections in places with deficiency. It just doesn't work here. And that's the end of the talk. And then I will go back to the beginning and tell you where all these pictures were taken. So Turkey is the upper left. No, wait, Turkey's the right. Upper left is Cambodia. Lower left is that I believe is in Africa, and then lower right is Vietnam. But I didn't get gastro from any of these places. So this is an dispersion. The only time I think I've really ever gotten gastro recently from street food was in Morocco. I ate like a street egg pizza thing, and usually when I get anything, it's like I just get a little burpy, and then my wife gets quite ill. Questions about anything?